Hi, my name is Rosie Donoghue. I'm one of the physiotherapists here at Wessex Rehab, and today we're going to do a session on hypermobility spectrum disorders and hypermobile Ehlers-Danlos syndrome. So the aim of today's session is to have a better understanding of hypermobility spectrum disorders and hypermobile Ehlers-Danlos syndrome, where hopefully you'll understand the similarities and differences between the two conditions and how they're categorised. We'll look together at how the conditions affect the body and the management and therapeutic strategies around them. And we're going to finish off with a plan as to how to move forwards in your care. Sorry. Okay, so what is hypermobility? So hyper means excess and mobility means movement. So hypermobility is when there's too much movement in the joints in the body. So to understand the condition, we need to learn a little bit more about collagen, because that's where the cause is thought to stem from. Collagen is found widespread throughout the body, and it can help to explain why many people have a variety of widespread issues, and it's not always just associated with the joints. So what is collagen? So collagen is a protein and it's the main building block of the body, and it provides strength and support to the ligaments, tendons and cartilage. It's one of 4 types of tissues found in the body. So it's called the connective tissue, which is one type, and your other types are your muscular tissue, your nervous tissue and your epithelial tissue. But the connective tissue is the most prevalent, it's the most common found throughout the body. It has lots of functions, and so it provides kind of that binding and supporting to the joints and to the body and the different systems. It protects, it strengthens, it insulates, it stores reserve fuel and helps to transport substances around the body. In patients with hypermobility, it's thought that the genes that instruct the collagen to be made is defected and causes the collagen to be more elastic than it should be. This happens when the DNA is formed as an embryo, so even if the symptoms aren't present until later on in life, the cause occurred much earlier, before birth. And symptoms can range from mild to life-threatening. Symptoms can be in one joint or widespread. Symptoms can change over time and can often be misdiagnosed or undiagnosed. And some people may have no symptoms at all. So how common is hypermobility? The answers kind of, from looking at different articles and research, vary between about 15 to 30% in the population of children and adolescents. Now that's quite a wide statistic, and that's because it's not that well reported or not that well diagnosed as a condition. And it's thought that it decreases that percentage as we get older in the population. It can be localised, so to one joint, or it can be widespread. It's more common in children and adolescents, it's more common in females and those with an Asian or Afro-Caribbean background. It tends to lessen with age, and many people are asymptomatic, which is when there's no symptoms at all. People have a wide range of symptoms, which can kind of range from no symptoms or very mild symptoms to wide complex symptoms. And there are some advantages to being hypermobile. So you can see here in the different pictures there that there are different sporting activities or musical activities where the extra range at the joint can give an advantage. We call this asymptomatic hypermobility, and that's when someone is able to kind of have that increased range of movement at the joints and don't have any symptoms as a result of it. So let's talk a little bit about the names. So we've got the hypermobility spectrum disorders versus the hypermobile or hypermobility Ehlers-Danlos syndrome. Different names, but are they different conditions? So in 2017, they did a big review of the two conditions and the different names and the terms that were given to them. And they've now decided to classify them in a new system. But the important message is that if you were diagnosed before 2017, you do not need to be reclassified. And that's because the treatment for both the conditions remain the same. Now here's a really helpful table that describes the different types of hypermobility spectrum disorders and the hypermobile Ehlers-Danlos syndrome. So you can see in the first column there, you've got your asymptomatic hypermobility, and they're the first three, and that's your generalised joint hypermobility, your asymptomatic peripheral joint hypermobility, and your asymptomatic local. So that's to do with where the hypermobility is found in the body. And you can have that asymptomatic, or if you go down lower in the columns, you've got your symptomatic ones. At the bottom there, you've got your historical hypermobility syndrome disorder, or spectrum disorder, sorry, and that's when someone once had hypermobility, but as they've got older, their joints might have stiffened and their elasticity has reduced so that they do not kind of fall in that category of hypermobile any longer. And then you've got your hypermobile Ehlers-Danlos syndrome at the bottom. In the middle column, you've got your Baton score, and that's a really helpful measure just to look at the degree of hypermobility across the body, and we'll look at that in a moment. Now, just something kind of to note really here is that a lot of people can have what we call asymptomatic hypermobility, and that's when there is no pain or symptoms as a result. And I think it's important to recognise that, because hypermobility does not automatically mean that you have pain, disability or health problems. Many patients who are given the appropriate advice and support when their symptoms start may find that symptoms improve significantly, and their diagnosis can change from, for instance, having a diagnosis of generalised hypermobility spectrum disorder to what we call asymptomatic hypermobility. I've just written them out myself just to make it a little bit clearer maybe. So we've got those 5 different categories. So we've got your asymptomatic, your localised is when it's in your fewer than less than or less than 5 joints in the body. Your generalised is when it's more than 5 joints. Your peripheral, when it affects just the hands and the feet. And the historical, where it's found in older adults who had progressively lost their hypermobility. This is quite a nice kind of graphic, just again looking at that along a scale with the hypermobile Ehlers-Danlos syndrome at the end there. So looking at diagnosis, to understand the differences between the conditions, we need to look at how they're diagnosed. So firstly, let's look at the diagnosis of Ehlers-Danlos syndrome, because this needs to be ruled out before a diagnosis of hypermobility spectrum disorder is ruled in. So Ehlers-Danlos syndrome, there are now 13 different subtypes, all of which affect the connective tissue, and they all are thought to have a genetic cause. Each different type has similar characteristics, and there can be some overlap between the presentations of the different types. But they're all generally characterised by joint, skin and soft tissue flexibility and fragility. And Ehlers-Danlos syndrome is thought to be one of over 200 different connective tissue disorders. So here's the diagnostic criteria. There you'll see 3 different domains. We've got domain 1, domain 2 and domain 3. So you need to have each of the 3 domain to have a diagnosis of EDS or Ehlers-Danlos syndrome. And the second domain, you'll see 3 subcategories, or A, B and C. You need to have 2 out of 3 of those subcategories. And in the third domain, it's ensuring that any other type of connective tissue disorder, including any other types of EDS, has been ruled out. So this is the 9-point Baton hypermobility score. The Baton scale is used to identify hypermobility. 1 joint is given for each of the following joints with a total score of 9 points. Where the joint is bilateral, so that's on either side, 1 point's given for each. So you'd have 1 point for your left thumb, 1 point for your right thumb. A score of 6 or above indicates hypermobility. It should always be borne in mind that the Baton score only covers a small number of joints and only considers one plane of movement. If the individual scores low but has widespread hypermobility outside the Baton scale, then a generalised hypermobility spectrum disorder diagnosis might still be appropriate. So once the Ehlers-Danlos syndrome has been ruled out using that criteria we've just looked at, then a diagnosis of hypermobility spectrum disorder is given, and one of the 5 types is given, which we've kind of looked at already quite a bit today. So any confusion over names? My main or one of the main messages from today will be not to get bogged down with the names. The most important thing is to focus on moving forwards, and the treatment for both of the conditions remain the same, and therefore the name will not change your treatment. So try not to worry about the label. So from now on, we're going to refer to both conditions as hypermobility. So let's look at some of the symptoms. Common symptoms that we see here at Wessex Rehab are those symptoms around pain. It's probably the most commonly reported symptom, followed by subluxations and dislocations. Soft tissue injuries, so conditions such as epicondylitis, tenosynovitis and bursitis, are conditions of the soft tissue which are normally related to overuse of the joints or the tissues. Fatigue is very commonly reported, sometimes what we call chronic fatigue syndrome. Low stamina and exercise tolerance, muscle weakness and deconditioning, poor space awareness known as proprioception, and often that looks like in patients it's reported of kind of feeling like they're clumsy. Poor movement patterns and adapted postural positions, this often as a result of pain or fatigue, and how patients can adapt certain positions that are more comfortable, or what we call positions of ease, but can cause problems over time. Flat feet, scoliosis or kyphosis, and that's to do with the positioning of the spine, and anxiety or depression. There's also a growing recognition of an association with other concerns or other parts of the body or systems, and that's because of the collagen, which we looked at the beginning of the session, is found widespread throughout the body and not just within the musculoskeletal system. So other systems commonly reported are those around cardiovascular symptoms, heart valve problems, gastrointestinal problems, so stomach and bladder and bowel problems, poor response to local anaesthetic, pelvic floor weakness or gynecological problems, so such as prolapse or incontinence, influence of progesterone, so that's your menstrual cycle, and there's a recognition that as kind of people have the menstrual cycle each month, that they might have more or increased symptoms, and I think that's been quite kind of heavily looked into and researched at the moment. It's thought to be potentially due to the kind of change in hormone level, which also might explain the next point about complications in pregnancy. Prone to fractures is another problem. Eye problems, so cataracts or retinal detachment. POTS, which is to do with change in blood pressure, which goes with the change in position. And Chiari malformation or craniospinal instability. Now, if you are concerned about any of those, I would encourage you just to talk to a physiotherapist who will be able to direct you onto someone to talk about them in more detail. So here's a really helpful image just to help emphasise really that there is often lots going on in patients with hypermobility, and not all of it is seen. So often the top of the iceberg is that we see around maybe the musculoskeletal system, the sprains, strains, subluxations or dislocations, but often patients have going on unseen a lot of other problems. So let's look at treatment. There's no cure, but the treatment of the symptoms as they arise, and often that involves patients being seen in lots of different departments. So often patients will have onward referrals to the appropriate department depending on their problems. But let's look at the therapeutic options. So it's important, and hopefully the time you'll spend with us, you'll be looking at building up your core strength, some specific joint exercises. Now that will look different to each patient, but if you have some specific joint problems, then talk to your physiotherapist and they should be able to provide you with some specific exercises. Balance and proprioception exercises, cardiovascular exercise, Pilates and Tai Chi. Now I put query yoga, and that's because for some people might have been told before yoga isn't good. I would suggest that there's no problems with yoga unless you're having issues kind of as a result of it. So the main kind of caution is to avoid taking your joints to end of range or kind of that stretching of the joint. Especially kind of persistent stretching over time isn't good because if you've already got more movement at a joint, you don't want to kind of increase that. So talk to a physiotherapist if it's something you'd like to do, and they can advise as to how to do it safely. Hydrotherapy, it can be really helpful. It helps to offload the joints and again just to enable you to do exercise in kind of a safe, protected way. Looking at movement patterns and posture education, and that's around trying to find the most efficient way for you to be using your energy. Manual therapy, soft tissue work, stretches, taping and acupuncture. Now I've popped those all together. They can be helpful and they're helpful therapeutic options, but I've popped them all together and just said to use those with caution. I think we don't do them much here, and that's because we really want to advocate patients self-managing their condition, and we want to help you learn tools to manage your condition going forwards and to be as reliant on others as little as possible. But that's not to say that there isn't a place for these at the appropriate times. Weight management, if you are overweight, then that does cause extra stress and strain on your joints. Pacing, sleep hygiene and pain management. So here are a few do's and don'ts. Just looking at do's, it's really important that you understand your condition and how it affects you. It's important to find the best management strategies that will help you gain control over your condition. To find a regular form of exercise that you enjoy and that doesn't flare up your symptoms. To use a graded approach, which we'll talk about a little bit more in a moment. And to have a healthy lifestyle and making decisions that help you look after your body. A few don'ts. Don't do what we call party tricks, and that's as we often see it in children or adolescents, where they can do fancy moves or positions because their joints have that increased range of movement. And long term, that's not good to be taking those joints to the end of range and repeatedly doing that, so avoid that if possible. Don't become over-reliant on braces, supports or aids. Now again, they can be really useful and they do have their place, but I would encourage you not to become too reliant on those. And don't do aggressive stretches or repeatedly taking your joints to the end of range. And finally, let's just look at how do we do how do we progress and how do we kind of have a graded approach to our rehabilitation. So often people find that there's certain types of exercise that are easier than others, and they're often the ones that are low impact or have low shock kind of exercises, and that can be cycling, swimming, Pilates or other forms, but they're good places to start if you wanted to look at doing exercise. It's important to find exercise that you're able to do comfortably and consistently before moving on to the next form of exercise or progression. Make sure you take small steps in the way you progress your exercise, remembering that you can't run before you walk. And every patient is different. The way you progress will depend on your individual patient goals. So thank you, that's the end of the session today. We'll now have a chance just for any questions to the therapists, or if you have any further questions, also you could discuss them with your key therapist. And I've just got as well a few helpful websites if you wanted to go and do some further reading. All three of those websites are really good and have a lot of information around hypermobility. Thank you.